Welcome to our last podcast on the cardiovascular system, and what we'll focus on in this unit is the changes that happen between fetal and neonatal circulation. Then we'll also look at some of the more common congenital anomalies that can occur with the heart and the cardiovascular system. So when we look at fetal circulation, there are some differences that we see that are unique for the fetus that will be changed, altered, closed, if you will, between the time you are in utero and when you are a newborn. And these structures are the ductus venosus, the foramen ovale, and the ductus arteriosus. Now in this list, the foramen ovale is one that we're fairly comfortable with now after looking at podcast 2. Foramen ovale is the unidirectional valve that allows the flow of blood from the right atrium to the left atrium and not the backward flow of blood. And this is going to fuse together at birth. And we've already seen and discussed that this is going to become the fossa ovalis in the adult. Now, when we look at the ductus venosus, this is going to essentially be a bypass of the liver. And again, venosus refers to the flow toward the heart. So what we're going to see is that where we have the umbilical vein coming back in, we are going to have an extra vessel called the ductus venosus that is going to run about half of the blood returning from the placenta past the liver and onto the heart. Now, most of the changes that occur at birth and after birth are going to be due to changes in blood pressure. And so this is going to be the case as well. There is a physiological sphincter that will close when we see these blood pressure changes. And so our ductus venosus will degenerate and blood will then start to pass through the liver and be part of the hepatic portal system. Now, when we look in the atria of the heart, we can clearly see our foramen ovale here in the middle, this unidirectional valve. We can see the leaflets, and remember these are derived from our septum primum, septum secundum, and this valve of the foramen ovale allows this flow of blood. And so we also have, this they call this the inferior border of the septum secundum, this portion hanging down. But the arrangement and the angle of the septum secundum is also going to help move this blood through this opening. You see the inferior vena cava and the foramen ovale are going to be lined up just perfectly for this high pressure blood to flow back. And it's high pressure, remember, coming back from the placenta. High pressure blood to flow directly into this area of the foramen ovale, directed not just by the flow, but also by the contours of this end. And we refer to this as the crista dividends. This is going to play a functional role as well. Now, when we look at fetal circulation, it's going to be a little different than we see. So structures that are going to receive the most heavily oxygenated blood, certainly the coronary arteries that are coming directly from the base of the aorta, the head, the neck, the upper limbs, and you can see a common theme here. These are going to be the structures that are developing ahead of structures in the posterior part of the body, and the liver as well, since we are getting some blood returning through the liver from the umbilical vein, not necessarily taking that bypass. The remaining oxygenated blood then is in the right atrium, and it is going to mix with oxygen poor blood coming back from the superior vena cava, and that's all going to mix together there. Early on it's going to be the sinus venosus, but then in the right atrium. Now we go from being highly oxygenated to being considered moderately oxygenated, and this is going to leave that right ventricle through the pulmonary trunk, and we're heading for the lungs. But remember, the lungs really don't do much because they're filled with amniotic fluid. You're not going to do a ton of gas exchange. So only about 10% of the blood in the right ventricle is going to make it to the lungs. The remainder is going to be shunted from the pulmonary circulation through a passageway and a bypass. It's called the ductus arteriosus. So as we make our way into the pulmonary trunk and we're moving upward, we get to the T intersection between the right and left pulmonary arteries. I'm trying to paint you this picture. We'll see it illustrated in just a moment. But at that point of the intersection, there is a bypass that if you just continued straight through that intersection, if you think of it in those terms, there's a bypass that's going to take you from the pulmonary trunk. When you get to that T intersection, just keep going straight and it will connect with the aortic arch And that way, 90% of the blood leaving the ventricle, this moderately oxygenated blood, is going to go straight from the pulmonary trunk through the ductus arteriosus into the aortic arch. Now, once we get into the aortic arch, we're going to see that about 65% of the blood that makes its way down the descending aorta, this is going to be recycled or recirculated through the placenta. So here we have illustrated what we saw in our last podcast with our fetal circulation. We have the placenta. Here we have the umbilical vein coming back, and I love that it's painted red, even though we call it a vein, simply because it's oxygenated. We call it a vein because of the flow of the blood. Now, here is the ductus venosus. You can see the bypass. And there's our physiological sphincter that's going to close off at birth to shunt the blood then into our hepatic portal system before we get into our vena cava. You can see coming back from the body, we do have deoxygenated blood mixing through the hepatic portal system, and it is flowing. And here's our superior vena cava. All this blood is dumping into the right atrium. We see some of that blood. A lot of this highly oxygenated blood is going to make its way through the foramen ovale to the left side. Here in purple is that moderately oxygenated blood we talked about, mixing between some of the blood coming in from the umbilical cord, mixing with the oxygen-depleted blood coming in from the superior vena cava. And as it exits through the pulmonary trunk, here is our ductus arteriosus bypass. You see, we get to our T intersection where in the neonate adult, we have to pick. Do we go right? Do we go left? Well, in this case, the blood continues on straight. 90% of this blood is going to go straight into our aortic arch, and we continue with that moderately oxygenated blood down through our dorsal aorta and descending aorta. And then 65% again is going to recirculate through the placenta, through our umbilical arteries, and back into the process all over again. So just a reminder, let's watch that video again, putting this into motion. So at birth, what we're going to see is changes to that fetal pattern to resemble more of what we know as an adult type pattern. So we've already mentioned this physiological sphincter of the ductus venosus constricts and shunts blood through the liver. The foramen ovale closes, and that's going to be due to the increased blood pressure in the left atrium once blood starts flowing through our own lungs. The ductus arteriosus and our umbilical arteries are all going to constrict because we no longer are going to have flow necessary or needed through these structures. Now, these structures that do constrict and the ones that close, these four, we're going to see them transformed into our adult remnants of these fetal materials. So the ductus venosus, the bypass of the liver, is the ligamentum venosum. It's just going to be a collagenous connective tissue cord that remains. The foramen ovale, when it closes, is going to be a shallow depression in the interatrial septum called the fossa ovalis. The ductus arteriosus is the ligamentum arteriosum, and you will be able to palpate this with a gloved hand as you're doing your gross anatomy. You can even do this in comparative anatomy with the cat heart, and, well, the sheep or the cow's heart if you're able to find one that's got the aortic arch still attached. And then our umbilical arteries, sometimes they're called the median umbilical ligaments, but another name for them also is the ligamentum teres. For comparison to the previous illustration, let's begin at where we had our umbilical cord. Notice that at the umbilicus, we can see the remnants of our umbilical vein. here, connected to the umbilicus, this is the round ligament of the liver, but when we get to the bypass, that's going to be our ligamentum venosum rather than our ductus venosus. Here are our umbilical arteries, the ligamentum teres. Here we're seeing them listed as the median umbilical ligaments. At the very top of our T intersection now that we know, there's our little tendinous cord that is the ligamentum arteriosum, and our shallow depression that no longer will open, mainly because of the pressure in the left side pushing this closed. But over a short period of time, that forced mechanical closure is going to result in the fusion of this tissue with the rest of the septum and completely closing that off. Now let's compare the end of fetal circulation with our new neonatal circulation in this video. So far we've seen everything that normally occurs during cardiac development and the development of the vascular system. Now we're going to examine what things go wrong in the developing cardiovascular system. And one of the things that could happen is the heart could actually be mirror imaged as it sits in the chest. So what we consider to be left and right, imagine that being completely flipped. Now, dextrocardia is what this condition is called. And if it's isolated, basically, you're going to have a lot of problems, because now we've got the aorta sending blood to the pulmonary circulation, and it's a closed system. The pulmonary trunk is now going to be connected with the systemic circulation, and that's going to be a separately closed situation. So if you have isolated dextrocardia, this is not compatible with life, and you're going to have to switch the great vessels, the pulmonary trunk and the aorta, to allow for those flows to be restored in their appropriate settings. Now, in the case that if you have dextrocardia associated with a condition, and actually a part of the condition that's called situs inversus, this is where all of your internal organs are mirror image rotated. Now, if all of the organs and all of the blood vessels are rotated and the heart is part of that, it's going to be asymptomatic. You're really not going to have any other defects. It's just everything thinks that the right is the left and the left is the right. And it's a little bit weird when you first see that. See, normally you have this beginning, this bending of our tubular heart. Well, with dextrocardia, it simply bends in the other direction. And if this is associated with the other organs and the other great vessels also moving in the opposite direction, then it is asymptomatic. It's the isolated form where only the heart is mirror image flipped that there's severe problems. Now, there's a huge set of defects that are referred to as atrial septal defects, or ASD. And this is the most common congenital cardiac anomaly. And for whatever reason, we see more ASD occurrences happening in the female population than in the males. Now, the majority of our atrial septal defects, a lot of laypersons will say, it's a baby was born with a hole in its heart. You probably heard that before. Well, in this case, we're talking about a foramen ovale that has failed to completely close. Now, there are various severities to this closure, and the most common ASD is referred to as patent foramen ovale. And most of these are going to be very, very small. And you can comment on the size of that hole in various ways, and we'll look at those in just a moment. But once we see these patent foramen ovale, the hole that is present, we're going to see that there are likely going to be other problems. that are associated in complications with this. You're going to have the increased blood pressure on the right side because of that shunting of the blood from the high pressure left to the right. We're going to see that's going to tend to dilute out the blood or decrease the amount of blood that's actually going into your systemic circulation. So it's going to be critical that we close that opening as soon as possible. If it's a small hole, it's not going to be a huge problem. But the larger the hole, the greater the chances of you seeing something on the order of cyanosis. And this is where you have that poor oxygenated blood, because a lot of the oxygenated blood is now moving back to the pulmonary circulation. It's almost like it's a closed cycle. And so less oxygenated blood is available to move to the remainder of the body. Now, a small hole we call a probe patent foramen ovale. And what they're talking about is a probe that maybe you use in comparative anatomy dissections would fit into that hole. That's how small we're talking about. And 25% of the population do in fact have probe patent foramen ovale. However, this is also usually asymptomatic. Maybe when you get into situations where you're doing something very strenuous or with other complications, it might worsen the severity of what's going on with the atrial septal defect. For all intents and purposes, this quarter of the population have no idea they have a patent foramen ovale. So in this illustration on the left, we can see the normal closed fossa ovalis. And in this case, simply because of the failure of either the septum primum or the septum secundum, or maybe the apoptotic events led to a larger than normal foramen ovale, we're going to have a slight opening that remains, and you can see that very slight opening, the probe patent foramen ovale. Now, as the hole gets larger, we're going to have more and more problems. And some other problems that we can have that are more clinically significant forms of atrial septal defects that may also impact our foramen ovale are going to be ostium secundum defects, endocardial cushion defects, and this may also occur with an ostium primum defect, sinus venosus defect, and probably one of the most severe is common atrium, where you simply fail to form the interatrial septum. So ostium secundum defects, we're going to see that we don't get quite the normal resorption of that septum primum. And this is going to change where we form that septum secundum. And this is going to result in a much larger opening for the foramen ovale. And so this will fail to close sufficiently. Thus, we're going to have something worse than a probe patent foramen ovale. Children is not going to be a big deal. But once you get into your 30s, you may begin to see some pulmonary hypertension. And here we're going to have a case where we can actually do surgical repair of this opening. Now, this surgical repair of the opening is, it used to be a big deal, open heart surgery, but these days it can be done with a catheter event. So when we see the situations that we have here, and again, we can see we have our normal foramen ovale, but a short septum primum, so we have a fairly good-sized hole. Even larger hole. Here we have a really large, basically almost an absent interatrial septum. But all of these different situations we can actually close off, and here we can see an actual heart that has this. If it's a smaller, maybe an ostium secundum type defect, we're going to be able to close those off with a set of almost like shunts that are used, the cages, the wire cages that are used to shunt vessels to open up with angioplasty. These are going to be used in a very unique way. So let's watch a video of how we can actually close some smaller or even intermediate sized atrial septal defects. The next type of defect that we see in the atrium are going to be caused by problems with the endocardial cushions. And endocardial cushions are going to contribute much tissue to the closure of the ostium primum, as well as to portions of the ventricle, the medial flaps of our AV valves. And so in this particular case, we link together endocardial cushion defects and ostium primum atrial septal defects. Now, what's going to happen, and here it's not patent foramen ovale, it's patent foramen primum. That's what that should read. And what we're going to see is because we fail to form those atrioventricular cushions, we're not going to close off that initial hole, that crescent-shaped hole that's forming in the septum primum. And oftentimes because the cushions, there's a problem with them, we're going to have a common AV canal. Now, this is much less common than, say, a patent foramen ovale or some of the other defects we've seen. But where we're going to see it in high incidence is in individuals with Down syndrome. Many of these individuals do have atrial septal defects, congenital heart defects, and 20% of patients with Down syndrome do have these endocardial cushion ostium primum defects. So in this illustration, we can see the closure forming the fossa ovalis, but here we have that remnant. This is a low atrial septal defect, they term them. High atrial septal defects occur here, and we have a patent foramen primum in this case, and you can see the blood is able to mix, and that's due to the lack of material from the endocardial cushions. Now, sinus venosus defect. This is going to be one of the rarest, if not the rarest, type of atrial septal defect. And with this, we have a lot of correlation. We don't have necessarily a lot of cause and effect. But certainly we know that we have abnormal absorption of the sinus venosus into the right atrial wall. Remember, this is where pacemaker activity is. So I'm not exactly sure how that's going to affect the rate and the pace of the heart, but it certainly isn't going to help. Now, we also see that we have a correlation with abnormal development of the septum secundum, which, it's hard to wrap your brain around that. But because we have this septum secundum issue, we're going to have a high atrial septal defect. And then we also see another correlation with abnormal pulmonary venous connection. Now, this one I really can't wrap my brain around because sinus venosus absorption is on the right side with the sinus venarium, whereas our pulmonary venous connection, what side is that on? That's right, it's on the left side. So basically here we're going to use an occluder type surgical fix and close up the defect. And again, we've got our fossa ovalis, nice and closed, no problems with ostium primum, but here we have our high atrial septal defect, and we can see that's because of abnormal formation of that septum secundum. Now, again, another one of the rarest types, and primarily because this is fairly incompatible with life, is the common atrium. You don't form any of the septa, so you have complete mixing of the blood. In this ultrasound image, you can see this is one large continuous atrium. And here we have a ventricle that has also a ventricular septal defect that we'll talk about next. Here we can see the membranous portion of our ventricular septum, but we're missing the membranous type. And that membranous type, that's going to be the more common type of ventricular septal defect. Now, for this individual, there's low chance of survival with this. There's no way to my knowledge, that we have at this point to repair a common atrium. So moving down to our ventricular septal defects, we saw with atrial septal defects that's most common in females. But the most common congenital heart defect, CHD, this is going to be the ventricular septal type, and that is most common in males, and it's going to be more common to be the membranous type. And this can be a very small hole, may not have much impact, or as we saw in the previous image, a fairly large hole that absolutely can affect the individual. Now, since we have multiple tissues that contribute to our membranous ventricular septum, we're going to see that if we do not form that partition in the outflow tract, our aorticopulmonary septum coming from those bulbar and truncal ridges, think back to when we were talking about that in the last podcast, or if we have a problem, as we saw with our ostium primum, problem with the endocardial cushion tissue, this is going to leave those holes present. Now, our clinical significance may be as little as dyspnea, which is difficulty in breathing, or we may be asymptomatic, or if the hole is large enough, we could have severe problems, cardiac failure. A lot of this is going to do with cardiac hypertrophy because of the changes of pressure. The muscular wall is going to thicken on the right side. That's also going to cause pulmonary hypertension, increased blood pressure in the lungs, leading to congestive heart failure, and that's going to be the likely cause of that with these large ventricular septal defects. Now, for the muscular portion, this is going to be much less common than the membranous type, and a lot of times this is going to be caused because if you think of cardiac muscle, it's going to typically be described as trabeculae carne, this meaty, kind of cavernous with holes in it. And if you form too many of these caverns, or these cavitations as they call them, and they interconnect one side to the next, then what you're going to end up basically is a muscular septum that's filled with holes. And this is often referred to as the Swiss cheese ventricular septal defect. Now, a very rare condition is common ventricle, like we saw with the atrium, and in this case that's referred to as cor trabeculaire, that should be a B, cor trabeculaire biatrium. And so in this case, that is French for three-chambered heart, your two atria and then your common ventricle. So in this illustration, we can see that we've got our two atria, right atrium, left atrium. Here is our outflow with our aorta and our pulmonary trunk. Here we have our ventricular septal defect. Now, they've also included a couple of things in this one that is not like a normal heart. Here we have what is referred to as a persistent truncus arteriosus. This is a common pathway, if you will, for blood. So now we're going to get the mixing of the oxygen depleted and oxygen rich blood in this early part before we partition. We're also going to get mixing through the ventricular septal defect, and because of this and the changing of pressure, as well as with this PTA, we can see that the thickness of the right ventricular wall is the same as on the left ventricle, so that's also going to lead to that pulmonary hypertension. Now, the next category that we're going to talk about here is transposition of the great vessels, and when we talk about great vessels, we're talking about the pulmonary trunk and the aorta. And this is going to be solely caused by the malformation of our aorticopulmonary septum. Malformation in that it's not that it doesn't form, it does form, it simply doesn't spiral. And without that spiraling action, we're not going to separate the pulmonary trunk from our aortic trunk. And so what we're going to have here, and those live births because of this, and the ones that survive, they're also going to be associated with a patent foramen ovale, a patent ductus arteriosus, or both, because when you look at someone that has transposition of the great vessels, you've got two closed circulations. So think about this. Blood's coming back from the body to the right atrium, goes into the right ventricle. Now that blood's going to enter the aorta and go back to the body. We never go to the lungs. Now on the left side, blood's returning from the lungs to the left atrium, left ventricle, and now it goes into the pulmonary trunk, back to the lungs. So you see our two closed circulations? The only way to get oxygenated blood to the body is through these bypasses, the patent foramen ovale and the patent ductus arteriosus. So those have to be maintained until we can surgically rearrange those vessels. Now, when you look at this at first, it doesn't look that bad. It looks fairly common. But notice, here we have the right side, boom, right into our aorta. Left side, right into our pulmonary trunk. Now, they also include a ventricular septal defect, and possibly that's going to be a common occurrence with this transposition of the great vessels, but I've not seen a lot of that. Maybe it's just for illustrative purposes. Now, the last defect to mention is referred to as teratology of Fallot, and a teratology is where you have a number of consistent problems that occur together in a set. And in this case, Fallot was able to describe in this particular situation where we have pulmonary stenosis, so a narrowing of the pulmonary trunk. We also have a ventricular septal defect, All of these things are going to lead to that right ventricular hypertrophy. But we also have dextroposition of the aorta, overriding aorta. It's going to override more toward that right side as well. So when these four things, these four defects occur together, it's referred to as teratology of Fallot. Now externally we can see the stenosis of that pulmonary trunk. It's extremely narrowed. And again, because you're not going to be able to force as much blood through that, it's going to hypertrophy the right side. So you're really going to enlarge the right side. Not only that, but blood's going to have a difficult time going into the stenotic pulmonary trunk. But now you've got the aorta overridden, so a lot of deoxygenated blood is going to move into the aorta, possibly through our ventricular septal defect, but certainly because of the ease with which blood can now move in to the aorta because of that dextroposition or overriding. So stenosis of the pulmonary trunk, overriding aorta, right ventricular hypertrophy, these are going to be all part of what we know as teratology of Fallot.